Hello, hello, everyone. Welcome, welcome, welcome. We are live here at the International OCD Foundation. So thank you so much for joining us a special Friday morning. This is a special live. Normally we have lives every single week. We have them Tuesday evening, usually at 7 p.m. Eastern time. That's where you'll see Diversity Roundtable. You'll see our Faith and OCD Talks hosted by Kitty O'Dunn. We also have our town halls, our community conversations with Ethan Smith. And then on Wednesday mornings at 9 a.m. Pacific Standard Time, you'll see myself and Liz McInbell. We do every first and third Wednesday of the month, we do an Ask the Experts where you can ask questions live. Every second Wednesday, Kyle King and John Abramowitz, they do a research roundtable. And then we do a lunch and learn for the Wednesday. Actually, the third Wednesday, the fourth Wednesday is the Ask the Experts. But the good thing is, I don't have to memorize things because at iocdf.org/live is all the information on live streams. But today it is a very special live stream. Obviously, it is June. It is the month of Pride. And all of us on this panel are clinicians that are absolutely dedicated to making sure all individuals, regardless of sexual orientation, gender, ethnic background, race, etc., receive quality evidence-based OCD treatment. And that's what we're going to be chatting all about today. So before I jump into my guests, because obviously you see my big head and then you see a bunch of beautiful faces next to me, and I'm going to introduce them in 1 second. But just a reminder, iocdf.org is your place for all information. Another thing I want to remind everybody that this live stream is here for educational purposes. We're going to be giving you resources. We're going to give you education. We're going to discuss topics, but we can't replace a clinician that can work with you one-on-one. So please make sure to go to iocdf.org/find-help if you're in need of a clinician. But if you are struggling or you're in an emergency, make sure that instead of relying on us, you dial 988, or you can go to 988lifeline.org, I believe is the website that you can go for help. And make sure to be respectful and support everybody. All right, so I'm going to jump right in so that I can introduce the folks on the page, because we have some really, really exciting things that we're going to be talking about today. And I want to make sure we have enough time to get into everything. So I'm going to start with Dr. Lauren Wadsworth. They are a board certified clinical psychologist, founder and director of Genesee Valley Psychology, a social justice oriented OCD, trauma, and DBT clinic located in Rochester, New York. Clinical senior instructor in psychiatry at the University of Rochester Medical Center, and diversity, equity, and inclusion senior advisory at McLean Harvard Medical School. She is a co-founder of Twin Star Intersectional Diversity Trainers and author of Did That Just Happen? Beyond Diversity, Creating Sustainable and Inclusive Organizations, an award-winning book on fostering diversity and inclusion in the workplace. How are you doing today, Dr. Wadsworth?
Great. Happy to be here. Thanks for the invite.
Yes, absolutely. Good to see you. Good to see you. And also, everyone, make sure that you go ahead and introduce yourself in the comments. Let us know where you're from, what brings you out to the live today, and who you're here to support. And also, if we have time, we will definitely get to some of those questions. So you can put your questions in the chat. My next guest is Dr. Caitlin Pinciotti, which I was about to butcher because it always sounds like an Italian pasta to me. That's what I always think of when I think of your last name, Caitlin. So hopefully that's okay. Or maybe I'm just always hungry. Is a licensed clinical psychologist, and an assistant professor in the Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. Dr. Pinciotti is an expert in the assessment, conceptualization, and treatment of OCD, trauma, and PTSD, and has a secondary interest in identifying and addressing mental health inequities in gender and sexual minorities. Welcome, Caitlin. How are you doing today?
I'm good, and definitely okay with you thinking about pasta.
I know. Every time I get an email from you and I see your last name, I'm always like, dude, I need some Italian food. I need to get a Pinciotti with a creamy pesto sauce is what I want. Is it even Italian, or is my hungry self?
It is.
Okay.
Yeah, it is. Yeah. Okay. You're on pace. Yeah.
Okay, good. All right, next is my buddy Amy Mary Askin, PhD, is a licensed clinical psychologist and founding director of the Nashville OCD and Anxiety Treatment Center. She provides individual and group therapy for people with OCD, anxiety, and OC spectrum disorder across the lifespan. She's passionate about working with children, families, and couples, as well as serving individuals in the LGBTQ community. Dr. Mary Askin is the author of the book Thriving in Relationships with OCD. Congratulations on the book, by the way. with New Harbinger Publications. Additionally, she is active in training and serves as faculty on the International OCD Foundation's BTTI as an adjunct faculty at Vanderbilt University. Welcome, welcome, Amy. How you doing?
I'm doing well. I want to know what kind of food I remind you of, but you don't have to do it on
Mary
the spot.
Askin. I don't know. It sounds like a Mediterranean dessert. Can I get Mary Askin? Hold the honey, but a little bit of powdered sugar. I need to eat breakfast before these lives, or else everybody's last name is going to turn into food. And then last, and of course, certainly not least, is Justine de Hager, who's going to correct their last name, because that's how I've been saying it forever, but it's because I speak Spanish and the J is usually silent. So it's probably Jaeger. Is an IOCDF advocate, member of the Diversity, Equity, and Inclusion Action Council, and participates in both the LGBTQ and Faith and OCD special interest groups. She is co-facilitator for her local goal group and works in political action for a Canadian labor organization. Justine holds a BA in economics and political studies from the University of Manitoba and an MA in public administration from Carleton University. She is dedicated to expanding access to quality, affirming, evidence-based mental health care. Originally from Winnipeg, Manitoba, she now resides in Ottawa, Ontario with her wife. Hello, Justine. How you doing?
Hello, I'm doing well. Basically, I'm the non-clinician. I'm the individual with OCD who's also pretty gay.
I always feel like I'm Batman, right? Like I have the clinician side and then I'm Bruce Wayne with OCD. So can wear both sides. Well, welcome. I'm going to start with a very basic question. Why is this important to talk about? I always think about, I wonder if people who are clinicians or members of our community with OCD ever see these lives and just think, what's the point of talking it? I think, unfortunately, many years ago, OCD treatment was very one size fits all. It didn't matter about your background. It didn't matter about your ethnicity, your race, your sexual orientation. We're going to shove that treatment down your throat. It's going to be the same every single time. I think, obviously, as we expand on treatment and we look at treatment from a DEI lens, we are serving more communities and we are making sure that the treatment is reaching people that need it. So I'm going to start with you, Lauren. Why is this an important topic to be discussing, not only on Pride Month, but just in general?
Yeah, to your point, Chris, that we often have treated treatment like a one size fits all. We know that when it comes to anxiety and the intersection with identities, there are nuances that could make different exposures safe or unsafe for people based on how they identify. So one thing that comes to mind is if a client comes into my office and says, I'm really anxious to go into public bathrooms, I might think, oh, is this OCD? Is it social anxiety? And without thinking about the identity lens, I might miss the real reason why that a bathroom is anxiety provoking. So in this example, if I was to delve deeper and ask about gender identity and expression and type of bathroom that a person would feel is most aligned with their gender versus what they're most comfortable going into, I might find out that the anxiety is actually about going into a bathroom that doesn't match the gender identity that people ascribe to that person. So they might be worried about violence or comments or not being safe in that bathroom, which would really impact the way we approach treatment, right? I'm in a social anxiety sort of treatment. I might say, go into that bathroom, let's do it. Let's do it together. But if there's an identity component like marginalization, I might be a lot more thoughtful about ways to approach a trigger like that in a safe enough way for that person. So I could go on, but I'm sure my colleagues have thoughts as well.
No, really well said. And I'm going to throw it to you, Amy. Why is it important for everything we just heard with Lauren? Obviously, being in our community, we might be a little bit more just quick to understand those nuances, but why should a clinician, maybe not in the LGBTQ community, but is obviously going to work with members with OCD in our community, why is it important for them to watch lives like this, go to training, see talks like this at the conference? What is that doing for their client base?
Great question. I think for a lot of people, coming into, and I know we're going to talk a little bit about sort of minority stress, but there are a lot of things experienced by people in the LGBTQIA plus community that are both like on a systemic and a personal level that are stressors. There are things that they're bringing into the room. And as clinicians, for people not to be sort of familiar with these issues or to be familiar with these contextual factors. They might be, number one, like Lauren said, they might be sort of pathologizing a behavior that truly is, based in reality. And I think by not being informed, if somebody comes in and they feel like they have to educate you about things like sort of basic terminology or gender identity, or if you're sitting there, you're not in the community and you're like, okay, male or female, or are you gay or straight, and you're not familiar with the fact that there are a lot of different either categories or that things can be fluid or what sexual identity development looks like, then you may you're not going to be a safe place to land, and you may be such an unsafe place to land that there may be people who are concealing aspects of their identity and coming in and saying, well, I just need OCD treatment. We don't need to talk about this. And then those factors which are impacting and intersecting with their symptoms in certain ways are not being addressed in a sensitive and safe way. So I think regardless of your identity or your experiences, or even the clients you think you're treating, I think this is really important.
You just reminded me of something. I remember when I saw one of my first OCD experts before I really found an OCD expert for my own care. My therapist which now I realize as a therapist, he shouldn't have done that because I was over 18, but he kind of met with my parents behind my back and said, look, I really think he's gay. I think that might be causing all of this stress. And so then the focus of treatment became my sexual orientation. I wasn't even out yet. I was so in the OCD, tornado. And it's like, that's what the treatment became about, put me in a very uncomfortable situation. He wasn't mean about it, thank goodness, because I don't think I could have mentally handled it at the time. But just what you're saying is if you don't understand these nuances and stuff, you're going to be providing care for your client that isn't going to be helpful at all. So well said. I want to throw it to you, Caitlin. We talk about what justice-based approaches. I feel like as we evolve ERP and the OCD evidence-based treatments, we're constantly refining it, making it better, and reaching more people. So can you talk a little bit about justice-based approaches in OCD and general mental health care?
Of course. So we use the term justice-based to define a treatment approach that equally respects and considers all people of society. So the client in front of you, their peers, the provider, and everybody else in society. We've sort of gone along for a while, and this isn't specific to the OCD space, but kind of with this assumption that being straight and cisgender is the norm, the default. And so we create everything sort of structured around that. And that's ended up leaving out a lot of people. And unfortunately, what that has meant is that some of the exposures that we've been assigning, kind of like Lauren was speaking to, haven't been the most sensitive for certain groups of people. And the reality is that, kind of to your earlier question too, Chris, that this isn't a niche area. We know that sexual and gender minorities are, 6 to 9 times more likely to be diagnosed or treated for OCD than their cisgender and heterosexual peers. And Amy, maybe you can correct me if I'm getting this stat wrong, because I know that you were also in this talk at an earlier conference this year. That there's some emerging research coming out that's showing that the rate of sexual and gender minority people in intensive OCD programs is continuing to increase year after year. And I believe this one sample out of McLean, somewhere between 30 to 40%, I believe, was their proportion of sexual and gender minority patients in their treatment programs. And so it's important for all of us, regardless of how we identify, to be considerate of what is justice-based treatment and how can we apply it, because more and more of our patients are identifying in this way.
Yeah, no, I heard the same stat. I was at a presentation where they spoke about that. And to me, it's like, if you're just not understanding how to work with that population or the, specific experiences they may be going through, and going in a residential, there's going to be additional situations like Lauren was saying earlier about restroom usage, about roommates and all those things, that if somebody doesn't even feel comfortable with the basis as they're kind of lending themselves to living in a treatment center, they're not even going to start to do the OCD treatment if they're not even comfortable with their living space, et cetera, in a residential. I'm going to throw it to you, Justine, as the person with OCD on the panel. What should people watching know about clinicians when working with the LGBTQ community, whether they work with OCD specific or any other comorbid disorder that we see in our field? What would you like people to know? What were some of maybe the things that you had in your treatment that went really well, or some of the things that you experienced that wasn't as good?
Yeah, I mean, I think a lot of it's kind of basic, but it's, the therapeutic kind of alliance, I believe it's called, a therapeutic relationship, right, is important. And if there's not some degree of trust that, the person you're speaking to, sometimes about really, scary thoughts, really like thoughts and obsessions that are really distressing to you, of course, in the case of OCD, it takes a lot of kind of trust and comfort to share that with anyone. And if there's also a feeling that, oh, I'm not accepted for who I am here, maybe I won't share as much about what I'm experiencing here because I might be judged more, that kind of thing. So, I mean, just kind of basic things, but, asking, when you're doing the intake, if, oh, you're married? Okay. What's your husband's name? Maybe not making that assumption, maybe saying, okay, what's your partner? That kind of thing. Not making assumptions about family structure, that either queer or trans people would or wouldn't be parents, that kind of thing. Just kind of, again, just there's things you can do to just kind of make the person feel comfortable. That's kind of on the like one-to-one relationship building piece. I did just want to touch on, though, in a way, we're starting from an interesting place in the psychology profession with respect to relationships with the LGBTQIA community. And this is true of a lot of care professions, right? Over the years, there's been a lot of changes. But, I learned recently that, the homosexuality was actually just removed from the DSM 50 years ago, which 50 years ago can seem like a long time. But when you think about people living today who very much lived through that experience of really conversion therapy, frankly, being the like cognitive behavioral therapy norm around, homosexuality, that's actually pretty recent. And there's a lot of maybe trust loss there. There's a lot of hesitation. And of course, the profession's done a lot of work since then to be far more inclusive and to, really, really denounce that practice as absolutely junk and actually harmful. But yeah, that history exists. And I think it's helpful to acknowledge and to show how far we've come and how far we can still go, including through things like these justice-based approaches to treating people of various minority identities.
Before I move on from this question, because I think it's super important, I wanted to open up to the panel either as a clinician or, I've been in therapy. Some of you on the panel may have been just not for OCD specific. What have you seen? Why is it important for clinicians? Like I just think about with OCD, somebody's already coming in such intense fear. They hold often a lot of shame about their content of their thoughts, and sitting across from someone not wanting to be judged in that space is already difficult. And we hear the horror stories of a mom with intrusive thoughts of potentially harming her daughter, and she goes into therapy and says that, and the therapist isn't versed in OCD and reports her. So there's already a lot of time fear on that. But I know you all really lead the way in making sure that treatment is consistently being done with DEI in mind. What are some of the changes either you see clients experience, you've experienced, or you've seen in your work shifting clients in the queer community as we're becoming more inclusive? What have been some of the tangible benefits that you've seen from all of this work that everyone's been doing? And anybody can take it on the panel.
So something that I'm really passionate about is demographic forms. Some of you already know that I talk about it all the time, but that's something that I think is really tangible and anyone could take away from this talk, or small things they can change on their intake paperwork and in their intake session. We know that people might be shy or scared or anxious or have past negative experiences about sharing their identities. So having multiple ways that clients can share can be helpful. So for example, in your intake paperwork, asking people what their pronouns are, not preferred pronouns, but what are your pronouns? What name do you want me to call you? What is your gender identity? And what is your gender expression? And then asking those questions again in the room in the first or second session, depending on how well you think the rapport is going. So if a person is really closed off, I might wait until the second or third session to do a full interview on all the different sociocultural identities someone has, just to hope that they've built some level of trust in me before going there. And after I do that, ask those same questions. I'll also say if any of this changes in the future, or if you want to talk about this in any way that's different than today, the door is open. And I'll try to check in every 6 months or so to ask if there are identity factors that are new or coming up for that person, or new questions, so that I'm modeling, using a Kenneth Hardy quote, as a clinician, if you have power to shape the room, you're the broker of that conversation. So by opening that door, by asking, what is your gender identity and how do you express your gender, showing someone that there are two different answers that could possibly come up for that question, you're saying it's okay to talk about that in this space. By asking, by opening the door to say, if any of this changes, let me know. You're opening the door to say, it wouldn't be weird to me if your sexual orientation was different in 6 months than it is today. Or if you share something with me that you weren't willing to share before. So by thinking about just the simple things like paperwork and questions that we ask in intake, we can model so much safety and learn a lot more about clients than if we just are working off of assumptions or not going through those questions. And what we've heard from clients, or what I've heard from clients, is a lot of, I was expecting a lot of clients to say, oh, why are you asking me? Of course I'm straight, or whatever. But actually what I hear more of is, thank you so much for asking me. I've never had a clinician ask me that before. And it's really cool that I'm at a place where this clinic is thinking about my identity. So I would just encourage clinicians to do that and to make those changes, because it can signal so much safety and create an amazing foundation for clinical work.
I wanted to expand on that. Thank you so much, Lauren. Expand on that with you, Amy. Some clinicians, how do you balance that? A lot of times clinicians will reach out to me and just ask some of these types of questions if they're struggling a little bit. And one question I get is they want to do the things that Lauren just said that's really important for them. And they happen to live in a state that isn't really supportive of the community, and potentially in a county that isn't very supportive. And they've gotten sometimes some pushback, or maybe they haven't gotten some, but they're concerned about pushback. I know that you're not in a California-like state like me. How do you balance sometimes some of that to make sure that you can be inclusive and support our community, and make sure that you're not worried about some kind of pushback? What can a clinician in that situation do?
That's so important. So I'm in the state of Tennessee, and it's one thing to talk about, stereotype and stigma and discrimination on an individual basis. And then it's another thing to talk about how there are things that have been codified, and there have been laws that are restricting healthcare access for certain people. So living in this state and knowing that there can be pushback, and frankly, we've had a little bit of pushback at my clinic, even for being affirming generally. But one of the things, and this is also kind of goes off of what Lauren was saying, is being able to have those, like an intakes, being able to have things that are asking about gender that aren't check boxes. So people can just write in and can feel free to write in and can express, especially since like terminology changes and people's expression changes and things like that. So I would say, that's one thing, to just kind of leave things a little bit more open. But I think, taking a stand and putting very clearly in your either on your website or when you're talking with people, making it clear that this is a place where we're going to consider all types of aspects of intersectional aspects of identity, including LGBTQIA identity. I think too, there's this, there are ways to, there are ways to make connections with other affirming therapists, even if things have to feel a little bit more underground. I hate to say that, but I think, for people who work with certain populations, for whom it's harder to access care, knowing the other therapists in your community, knowing the doctors and pediatricians and endocrinologists in your community who work with, say, gender nonconforming youth, making connections with them. And then, you know, and then I think when you ask those questions in interviews, if you have people, and Lauren, when you said that was so beautiful, when you said that people aren't like, well, of course I'm, you know, whatever, of course, this is my, I mean, we do frankly get some of that. Like, why are you asking about my pronouns? Can't you tell? And I think that's a moment to, you know, to just acknowledge, well, you know, you can't always tell, but, you know, I'll write that down. And that's not a moment in any sort of like, you know, this is a teaching moment, but it sort of is, in the sense that if you're avoiding asking about these things because of, you know, concerns about pushback, then what are the ways in which that's sort of complicit with heterosexism and transphobia and so forth? So I'm curious to hear if Caitlin has any like analogous experiences in her state. But I think like there are ways that I think just being calm and gracious if you get pushback, but also making those connections so that even if you're not as explicit on your website, other than, you know, sort of saying that you're affirming, that you can make those networks and have people find you and know that you're a safe space.
Well said. Did you want to add to that, Caitlin?
I think you described it all beautifully. Yeah, I mean, so I'm in Texas, and it's obviously a similar climate in terms of where things are with the laws. This hasn't come up for me quite yet, given like my recent move here and all of that. But I guess I would just add, you know, that we have an ethical obligation to provide the best quality care to our patients or clients, and that includes, you know, using chosen name, pronouns, all of those things, regardless of what some people who work in politics think we should do.
Well said. There's a certain person in Texas that just the thought of his face shivers me. So I apologize that you have to see him on TV probably more than I have to. A couple people actually from Texas. Justine, I want to throw the next question to you. I know that you're super active in the LGBTQ community in Canada. What is something that you see in the community of hesitation around getting therapy? I mean, we talked a little bit about conversion therapy and some other things that are quite frightening. Just when you're in the community, what are some of the things that people might see as roadblocks from their willingness to seek general mental health care or OCD care specifically?
Yeah, I mean, I think that is reducing, and I think certainly in Canada it's generally a better climate, though there is rising hate in some areas for sure. But yeah, I think it's generally maybe a fear of being frankly pathologized around one's gender identity or sexual orientation, as though that's the mental health issue, right, that requires addressing. Because frankly, that's how historically it has been done. And frankly, it's still done in a lot of, you know, certainly states. Conversion therapy, there's no ban in many states. In Canada, the ban was just enacted a couple of years ago. And the practice, we know, is still carried out, and it's treated as quasi-psychological, right, and therapeutic. And if people don't know better, you know, they might view it as valid therapeutic practice. We know it's not. We know that the evidence is in fact the very opposite. But yeah, I think it's the general concern of, oh, am I going to be, pathologized around my identity when in fact I'm, you know, my identity, my sexual orientation or my gender identity, of course, is part of who I am, but I might need treatment for OCD, schizophrenia, whatever it is, right? And it has actually nothing to do with, though, be informed somewhat by those identities.
Before I move on to the next question, one thing that you're active in the IOCDF's OCD and faith community and special interest group. In that group, obviously, sometimes there is some religious trauma or there is a hesitation for individuals that are queer to be a part of a faith community. And I know that that's some of the work that the special interest group is really trying to work on. So what are some of the things that you've kind of seen, or some of the ways that people with OCD can cross with a faith community and not feel like, okay, this is something that might be hurtful or harmful?
Yeah, it's tough. And it's, it's almost, I used to say it was like a coming out trifecta, right? Like coming out as like religious to my queer and trans community was an interesting experience. Coming out as, or disclosing I have OCD to the religious community, it's an interesting intersection between those three things. First of all, there are affirming faith groups and faith organizations, even within mainstream faith organizations that maybe have kind of as current doctrine not so affirming values or beliefs. There are often pockets of kind of LGBTQIA resistance, or people carving out their own space within faith communities, etc. But yeah, there's no denying it. There's a lot of particularly in a lot of mainstream religions, a lot of transphobia, a lot of homophobia that occurs, that has an impact on people, obviously, their mental health and then just generally over the course of their lives. And so, yeah, I think where possible also, especially right now, I think a lot of religions are frankly being weaponized and historically have been, but really right now, against the queer and trans community. So I think where there are faith leaders who oppose that kind of weaponization of faith against other human beings with human rights, I would strongly suggest that they speak out where it's safe to do so against that kind of practice. Because there are queer and trans people of faith. There always have been. There always will be. And yeah, but it's obviously an ongoing issue. Yeah.
I think Pete Buttigieg, I think when I was seeing him obviously running for president and now part of this current administration, being able to blend that as well. And I think that that's obviously a part of our community that there's still going to always be those nuances, but I'm glad to see that you're help leading the charge in the ISDF. I'm going to toss this next question first to Lauren, but I'd love anyone to jump in if you have any examples or any thoughts or feelings about this question. So what are some advancements made in CBT, including ERP Act, et cetera, over the past few decades with respect to LGBTQ people? And then where is there still room for growth? So I'll toss that to you first, Lauren. I know you gave us an example to kick off the show, but if you had any other examples or just things that you've seen or places that we need to go.
Yeah, thanks for the question. So first, when I'm doing case conceptualization, I would make a typical hierarchy of exposure ideas, and then I would usually alone and then with the client list out their identities and think about how those identities might impact exposure ideas and exposure safety, like I mentioned, and then talk with the client and ask them if there are any ways in which their identities might be interacting, and propose some ideas or thoughts that I had reflecting on it to show that I'm trying to do the work too and not just expect them to teach me about their identities. Some ways that we might adjust things are, instead of just doing exposure, we might want to do a little bit of cognitive restructuring first, which is something that we don't often do in exposure therapy, or I don't often do, but can be helpful to refocus and reframe our thinking. So for example, with that bathroom example I gave in the beginning, if it is that the person is experiencing anxiety about public bathrooms because of their gender identity and contamination fears, then we'd want to list out what those fears sound like, and then categorize them from and between OCD, maybe an OCD column, and then fears of stigma, and think about conceptualizing those as two different types of anxiety. One that we can target with exposure therapy, which would be the OCD related fears, and one that we can target related to problems by problem solving, and also targeting any internalized transphobia that person is experiencing. And by that, I mean locating any internalized fears, internalized transphobic thoughts, like it would be better if I wasn't trans, or trans is not normal. And then also identify thoughts around relative safety. And so when there's transphobic thoughts that someone is experiencing about their own identity, we'd want to target that with psychoeducation, and also locate any shame and try to externalize that. So that might look like validation first. So it's not fair that it's harder for you to go into a public bathroom than other people. And it's not because of anything wrong with you. It's because society was not built with trans people in mind. And that's not okay. So thinking about ways that we can shift that experience to bring up maybe anger or sadness as opposed to shame and guilt, if that makes sense. So we're seeing that shift happening related to identity in CBT broadly, which is really, really great. We're seeing more of that validation and then externalizing of minority stress. Another example that comes to mind would be if a blind person came in with social anxiety and said, I'm having a hard time in social situations because I think that people might be smirking or laughing at me and I can't tell. So we're not going to just treat that blanket with cognitive restructuring and say, well, what % likely is it that they're laughing and you can't tell? We would validate and say, you're right. You can't see if they're smirking, and you might be able to hear if they're laughing, but there is a lack of data. So we're not going to just restructure that thought. We're going to validate it and talk about how they want to navigate the world given that that difficulty they're experiencing. So those are just some things that I've seen, but I'm sure others have lots of other ideas.
Yeah, I would love to hear from anybody else on the panel to kind of expand on what Lauren said. And thanks, Lauren.
Well, I definitely think in ERP, I mean, I know this is it's been a little while now, but it's still slow moving. This idea of reducing terminology that sort of again sets up cisgender people or heterosexual people as sort of the norm, and then there's a it's a departure from the norm. So not using HOCD, using SOOCD, for sexual orientation OCD rather than homosexual OCD, which is not helpful, nor is it accurate, and is unnecessarily stigmatizing. I still see people sometimes saying TOCD or trans OCD instead of sort of gender related OCD, but I think those are some shifts that we're seeing just in being more mindful of language, and being more mindful as well of just that the affirmative therapy generally, like Lauren was saying, and taking into account the complexities, not chalking everything up to a distortion, and really being brave enough to sort of and maybe brave is not the right word, just being perceptive enough to step into somebody's shoes as well as ask them about their experience. What are the barriers to doing these that are not just anxiety? And I think, for a long time, it seems like ERP was used by some people sometimes as like a blunt force object of like, you don't like that, go do it. You don't like that, go do it. And, I think it's important to recognize, particularly if you're not somebody in the LGBTQIA community and you're working with somebody who is, and you are their therapist, you are in a position of relative privilege and power. And so failure to open up that discussion could lead to, to a breach of trust, but all kinds of harm and sort of, and really danger for your clients. So I guess that's another way of saying what Lauren said.
No, I think it was right. I like that analogy of like a blunt force object. I think when there's some real stuff going on with someone, and it just feels more real. I mean, I just think of my own personal treatment. I had a lot of relationship OCD in my first same-sex relationship. And I remember I was so lucky now in reflection that my therapist was very gentle on it, because there was some real confusion with me going on there. And I think if somebody would have taken a very like 1970s ERP, like we're going to do this and this and this, habituate. There was some exploring that I was doing, being somebody who, because of their OCD was so severe, I'm coming out and having my first same-sex relationship at like 24, which is a lot later than some. And I was genuinely trying to navigate while still dealing with the OCD, kind of both real life and that. And I appreciate that my clinician was kind of ahead of time. So I think what you're saying is so true. It's like we have to take that into consideration, or suddenly it's just it could cause damage, it can cause discomfort, it can cause confusion. And if anything, the treatment's supposed to open up and teach somebody something and give them strength and trust in themselves, not make it worse. Caitlin, I wanted to throw you kind of the same question. I mean, I was thinking about this question, when we're kind of looking over it. And I remember, when there's heterosexual people with sexual orientation OCD, sometimes I would hear, exposures of like, the client should sign up for a queer dating site and like go on a date with someone, or go to like a nightclub and pick someone up. And I just remember sitting, this was before I was a clinician, I remember sitting in the talks, hearing that and thinking like, oh my God, like people like me are being used as sort of like props for somebody's treatment. Do we let the other person know? Does that person know that they could be falling for someone who's only using them for treatment? So, have you still seen some of those kind of things, or do you feel like we as a community have sort of been able to evolve from that?
I think my answer is both. So I will say that, so the justice-based ERP paper came out last year. It's been about a year and a half. And I've been really like heartened by the positive reception that's gotten. I mean, we were invited to do the plenary at the IOCDF conference last year on the topic. Lauren was with me, of course. And a lot of people were reaching out saying like, thank you for this. Either like, I've always been doing it this way and there's been pushback, or I never thought of it like this. And now I'm going to sort of like overhaul how I'm approaching people who have OCD with sexual orientation or gender themes. So I think like largely the response that we've gotten has been really positive. And there are still people who say like, OCD is OCD. The content doesn't matter. If somebody's afraid of something, they do an exposure to it. And it's more nuanced when the OCD kind of implicates a marginalized identity, community, or characteristic. So I think it's sort of a both and. But if I can share some exciting news too, Lauren and I are currently finalizing. So hopefully this will be sent off soon to a journal. But finalizing a follow-up paper to the call to action paper that will cover other identities or characteristics that are sometimes implicated in OCD that can also be marginalized. So things like, racism, OCD, or fears about aging, disability, diagnostic status. Sometimes you see people having a fear of like going crazy or being psychotic. All of those sorts of themes that, just like with SO and gender-themed OCD, can implicate communities that are already being marginalized. So we're really excited about that work and providing more guidance to people about how to apply justice-based treatment to these other manifestations of OCD.
I just love that. Thank you for leading the way. I think people like me, I love tangible things that I can look over and stuff. So communications and conversations like this are helpful. And I think in our field, there's a lot of, research. I call myself a research nerd that likes to like read a paper and have something. So thank you for that tangibility. One final point, I'm going to start with you, Justine, but I'd love to hear from the rest of the panel as well on this. One final point on this question. One of the things that I receive sometimes, I think because of being part of the LGBTQ SIG, I'll get clinicians that are not part of our community and reach out and have questions, and I'm always willing. And one of the questions that I've gotten before is from clinicians that have maybe done some things in the past that, as we're talking about it, they recognize like, yikes, I was doing some of the things that you all have talked about we shouldn't be doing anymore. Feeling very just guilty, very shameful, things like that. As somebody with OCD and in the community, how should somebody watching this who feels like guilty or bad or is trying but they're making some missteps, like how can they best handle that? Because I think that's something I get a lot.
Yeah, for sure. Well, first of all, you will make some mistakes. We all do. You will. And the point is, are you trying to improve, right? So are you apologizing and moving on? If you maybe you use the wrong pronouns for a client, that could happen. You should apologize, but you move on, right? And you try to do better moving forward. And that's all you really can do. And so, I mean, there's a meta conversation here about OCD and not getting stuck in the like rumination about it, frankly, of, okay, so that happened. How do I move ahead? What's deserving of my attention in this moment? It might not be, I feel really bad about that thing. It might be, okay, well, how do I make things better moving forward? So yeah, the point is, if you're trying, that's fantastic. And if you're attending things like this and you're trying to, improve your practice, like that's wonderful. Yeah.
Well said. Did anybody else want to add to that?
I think owning it and doing a quick apology and moving on can be really powerful too. So coming to a team meeting and saying, hey, I learned this thing and I'm going to do things differently. And I'd like to apologize for anyone I've used as props. And then leaving it there, not going into a sob story or becoming the center stage, doing sad puppy dog eyes and asking for forgiveness, but just naming it, taking ownership, and then moving on.
Well said. Justine, before I move on from you, I know you're very passionate about legislative justice and obviously working in making changes on a legislative level. If you could wave a magic wand, like what is something that you would love to see legislatively that would support our community, either with OCD or just general mental health struggles? Like, what would you like to see?
Yeah, I mean, it's hard to pick just one, but I guess there's kind of two areas here. Because I mean, one, there's funding for mental health services broadly, right? Making sure that it is possible to have a system where people can access at relatively low cost, really high quality services, where clinicians are well remunerated for their work and have quality benefits. Like that system, legislatively possible. It just requires political will. That's a soapbox for another time. But we're going to talk about, we've talked a bit about minority stress, right? And quite frankly, like legislation that rolls back human rights is not good for people's mental health. Legislation that restricts people's access to healthcare, as Amy mentioned, legislation that, you're not allowed to learn about different family structures in school. Like if I'm a kid in elementary school and I'm not allowed to talk about the fact that I have two dads, that's probably not going to be great for me. So I mean, yeah, it's all connected, right? Where people don't kind of, it's not like mental health policy is isolated to just funding for services and how do we subsidize services and how do we ensure a accessible system. Those are all important things, but legislation that just affects people's day-to-day lives and their ability to exist in the world free from discrimination is part of it, and it has to be part of the conversation.
Absolutely, well said. Amy, I'm going to ask you the next question. With the current kind of political state and just everything going on, this Pride Month feels very different, at least for me. How are you seeing that sometimes influence the content of some obsession? So for instance, there was something that sparked in what Justine just said, working with a client that was very afraid, who has same-sex parents, and was very afraid that they would say it, even though our state obviously doesn't have the same restrictions as Florida or some others, but still obviously with that over responsibility that we experience with OCD, a lot of fear around what if I blurt out, and say my parents are queer, could I get in trouble? Could I be, they're very young and they were just very worried. So even on a young level, I'm seeing some of the constant conversations happening in our societal sphere impact some of my clients. What are some of the things that you are seeing, just the state of the world kind of influencing some things?
Yeah, I'll say that in the state of Tennessee, in working with young gender nonconforming kids, I'm having some pretty heartbreaking conversations that I think I don't think any person should have to have this conversation, but things like, kids might see something on the news and say like, well, people don't want us here. Like a little one said, like, people don't want us here. Like, should we move? And then you're also working with sort of developmental considerations of Black and white thinking and like, what does that mean? Like if I, can my family go into this state, and this state is okay, but this state's not, and so you're sort of grappling with helping, I know this is sort of tangential to OCD, but I really want it's called Pride Month for a reason. This is not about sort of just like, accepting and tolerating that, your orientation is this or your gender is this. It's about celebration of diversity and joy and community. And I think all of those things, when there are prevailing messages sort of in the ether that are talking about, people not having rights, or people being, unfit to parent, or things like that. With all of that out there, it's an additional factor, I think, in the therapy room that you're both, like Lauren said, you're acknowledging that's out there, and you're acknowledging either discrimination, stigma, what have you. But then helping people to access like queer pride, queer joy, gender euphoria, things like that. I honestly don't even remember your initial question. I just
no, it's all good.
Political, yeah. I think it's like it's a radical act to help people of all ages, and especially for me, the littles, to feel really excited about who they are and really proud of themselves when they're receiving messages, even if they don't quite understand the messages, which of course they don't. They're littles. So I think that's one thing that it's like both giving people a place to grieve and also providing a safe place to access joy. And again, being where I live, I think having that network, like Justine, when you were talking about faith communities that are affirming, we have the list of the temples and the churches and things like that for people for whom that's important, because it is about getting that community to network. I think that's a lot of, not provided that people are receptive to that. Yeah.
I think of like having OCD, I think my brain is a sponge. And a lot of times, like if there's high conversations going on constantly, my brain wants to make it about me and how is this you and danger. And that's just the OCD brain nature. And so I just worry because there's so many clients impacted that, because when we have OCD, our brain tends to do that. If there's a constant conversation, our brains figure out how to internalize it and cause, distress. So I think, just seeing that. The next question I feel is super important, and I'm going to call on Lauren and Caitlin, and I'll let both of you weigh in, and somebody can jump in first if you want. But one of the things that most important thing I think that I've seen shift in the community, I remember when I was a client and not being a therapist myself, I would go to a lot of the conferences and people would talk about taboo, intrusive thoughts, which I think is very important, because I think sometimes we're missing some of the community because people always see checking and contamination. So people learning that having distressing thoughts consistently and ruminating on them is important. One of the things that I really struggled with, though, is they would talk about individuals with at the time they called it homosexual OCD, but fears of being gay was usually the topic. Now, obviously, it's expanded to individuals that are cisgendered, afraid of being potentially trans, and vice versa. But when they would talk about it, it would sort of lump that in with other, intrusive thoughts. And I remember thinking, sitting in the attendance, like, wow, these people are just going on about how they're afraid of being gay, and it's like their worst case scenario, and they're afraid of it and they have to face it and all that. But it's just me. And I felt very, very belittled. So how do we make that balance where we can talk about for some people, cisgendered, heterosexual, having sexual orientation and gender-related thoughts is very distressing for them. How can we validate that, but still validate the queer community so nobody's really feeling kind of like shamed or belittled or othered? So like Caitlin, Lauren, if y'all want to jump on that, or if you want to say it's too difficult and we can't, we could move along. No, I'm just kidding.
I just want to give Caitlin a chance to go first.
Sure. This is a great question, and there are several layers to it. The first one being, again, going back to earlier when we talked about language and how important it is to use language that doesn't stigmatize people, whether intentionally or not. And the fact that we continue to lump, sexual orientation and gender identity into these like horrible, intrusive, taboo thoughts. We really need to take a step back and reconsider that. In this work that Lauren and I are doing, we're using an umbrella term of identity-related OCD. So OCD that attaches to any sort of identity. Now, obviously, as a researcher, my brain also goes to like, well, we need to like look at the data and see like how do all of these symptoms kind of hang together. That's where we sort of created these categories to begin with. But that work can be done, and we're collecting data right now that hopefully we can use to further that aim. But I think regardless of what the data shows, we can also just sort of improve our language. I don't know, Lauren, do you want to jump in?
Yeah, just underscoring, like, we do not need to include it in the taboo category. Like, we can just change that. We can just change that in our own language and name it when we're saying identity related OCD, and we're intentionally not calling it taboo anymore. We're not lumping it with pedophilia, which is just such a trans and homophobic thing to do. And when we're thinking about treatment and conceptualization, something else Caitlin and I talk a lot about in our work is getting underneath that surface level fear and targeting the underlying fear. So most commonly we hear straight folks maybe saying they're afraid of being gay. But we know that that happens in the reverse too, that gay folks worry that they're actually straight and that they're not in the right relationship for them. And trans folks worry that maybe I'm actually cis and I shouldn't have gone down this path of treatment. So it's not actually only about a fear of being gay. It's a fear of not knowing one's identity, and that one might not be living the most authentic life for them, or might not be capable of experiencing happiness at its fullest level if they're not with the right kind of partner, similar to our OCD. So really we're just being a little bit, digging a little deeper as a clinician, as a person with OCD, and asking, what am I actually anxious about? So by doing that, we can figure out that it's actually not about a fear of being gay. It's just a fear of uncertainty, which is at the core of all OCD, right? And by doing that, we can get away from the stigmatized exposures and target that uncertainty more directly, which we believe is actually more effective and less stigmatizing. So win-win.
We're not going to get time to my last question, but I'm glad you kind of answered it. A lot of times clinicians will ask, like, how do I know if my client is genuinely struggling with OCD, or could they potentially really be queer and are struggling because they're so used to doubting? But like you said, it's like when we stop on the surface and we kind of go deeper and deeper, what I see is exactly what you said. I have so many clients that are like, look, I have family and friends that are gay. I wouldn't even care if I'm gay. Why is it bothering me? And then there's that added level of distress. And it turns out it's a change of identity. They want to be certain, and they aren't certain right now, and that's causing distress. So I always tell people, go back to the basics. Justine, I'm going to give everybody a chance to leave everybody with one thing, but Justine, I'm going to kind of hopefully push yours towards tell people a little bit about the LGBT SIG and why it's important for people to come as one of the SIG's leaders.
Yes. So the LGBTQIA special interest group, it's a relatively new one. I believe, Chris, you actually started it a couple of years ago, maybe.
No, it's only been a year. It's
only been
short.
a year. Well, there you
go. It's a baby.
Okay. Well, I was a late joiner, but yeah, still relatively new. So we're building up a lot of initiatives, things like these live streams, some social media content, looking at some advocacy more generally. We meet monthly. There's information on the IOCDF website. It's a little Google form you can fill out to join our meetings. It's a great space to kind of be amongst like-minded folks. Allies who are dedicated to this work also are more than welcome to join. So it's a lot of fun. It's really important, and would love to expand our numbers.
Absolutely. Thank you so much. For Caitlin, Amy, and Lauren, final thoughts, any resources, whether it's clinicians, individuals in our queer community, any kind of resources or anything that you want to shout out, or any final thoughts?
I'd love to just plug our Pride OCD study. If folks haven't taken it yet and they're on the stream, OCD doesn't exist in a vacuum. That's what a lot of my research is on, is like, what are all of these experiences that kind of influence OCD? And so we are collecting data. It's the first study that's specifically for LGBT people with OCD. And we want to understand, how do these minority stress experiences that we've been talking about on this stream today, how do they impact people's OCD, whether it's their symptoms, whether it's the severity or the onset of their OCD. So please consider participating in the study or sharing with anyone who might be interested.
Well said. Lauren and Amy, anything you'd like to leave people with? Any resources or just final messages?
I don't have anything as exciting as that study, which is really cool. I guess I feel compelled to say one last thing about bisexuality and like the validity of bisexuality. I think and I know that there are many orientations and many gender identities and things like that we didn't talk about. I want to say something about in working with my clients who are bisexual. I think that I know in a lot of literature you see like where there's, straight people are worried that they're gay people are worried that they're straight, which again, like, of course, in a lot of like clinical vignettes, they're vignettes for simplicity. But I will say, if you're somebody out there and you're bisexual and you have OCD and you're in that place of, am I lying to myself this way, or am I lying to myself this way? Or I feel like there are in a lot of either fluid sexuality, bisexuality, or gender fluidity, that's a really right place for OCD, because OCD loves black or white. So I just want to say I see you and you're valid.
Well said.
Can I just jump in on that too? I think we say this a lot, but it does. Representation matters. And so that point, Amy, is so important. And I, in reading your book, I was just so excited that like some of the examples provided weren't just, cis kind of hetero folks and relationships. And, that stuff's huge. I would read it before bed and I'd turn to my wife and be like, look, it's us, or it's, someone else than the usual. And that was very exciting and very validating, I think, would be for people of a variety of identities. So thank you for that. And yeah, it's really important.
And I would just do a final plug on Caitlin's amazing paper in 2022, and I put it in the private chat, so hopefully it can be shared in the larger comments. This is a paper where Caitlin breaks down justice-based ERP and applies it to sexual orientation themed OCD, and has a table of exposure do's and don'ts. And the forthcoming paper that we're going to share when we can will have that same kind of table series for all other sociocultural identities. So would highly recommend checking out her paper.
Well said. And what I always tell people, because sometimes people watch this back on YouTube or and they'll say, oh, I wish I was there because I can't click the link. If you go to IOCDF's Facebook page, all of the things that are being put in the chat will show up there, so you can click it directly. Speaking of the chat, I want to thank everybody. I had too many questions to get to some of the comments, but I do want to say that I saw some of the comments. Kira, absolutely true. I remember the Y box content involves homosexuality, so I'm glad that we are getting better with that and expanding. The fear of lying to ourselves and others is very common. There was somebody who made a comment earlier about Miro on YouTube, about there's actually countries obviously where people are being killed and penalized for being queer. So many good points in the chat. What I hope you took away from this, either if you're a clinician or somebody in our community, is that people in the queer community deserve affirming care. They deserve care that is being, I don't want to say catered to them, but is keeping their experience in mind. That should not be something that is a detriment or a prevention from receiving quality OCD and related disorders care. So thank you so much for coming out and hanging out with us. Make sure that you share this with whoever you'd like. Either it's going to be on IOCDF's YouTube or their Facebook group. Please spread this. Please share it. Such an important message for Pride Month. So happy Pride Month. One last thing I got to plug is please come join us in July, the second weekend in July, I always say the 6th through the 9th because there's so many Thursday activities, but we will be in San Francisco for the IOCDF in-person conference. I'm so excited of seeing some of these people on screen in person. It's been way too long. Make sure to come out to the conference. The link is on the screen. My final thank you is for the 4 beautiful faces you see next to me. And I just want to thank them for taking time out of their busy schedules. They are leaders in our field, and for them to come out and support on the IOCDF's mission for Pride and to support people watching this is an honor. So thank you, you four, for coming out. Have a great rest of your day. Happy Pride. And there is hope to get better from OCD. We are all living proof, those of us that have gotten better. So thank you for coming out. Have a great rest of your day. Happy Pride.